All right. Hi, and welcome to another conversation with clinician researchers. My name's Ray Thomas, and I'm the Research Education Lead for the Tropical Australian Academic Health Centre, known as TAAHC. Today, we're speaking with Vinay Ganathimmaiah, and a staff specialist and emergency physician at the Townsville University Hospital. Welcome, Vinay.
Thank you, Ray.
So just before we get started, tell us a little bit about your role in the hospital. What is it that you do?
So I'm one of the staff specialist emergency physicians here at the Townsville University Hospital. So I'm one of the consultants. So as part of my job, I have both clinical and non-clinical responsibilities. Obviously, with my clinical responsibility, I look after patients who present to the emergency department. And my non-clinical responsibility is research. So research is my non-clinical portfolio, and I'm the director of emergency medicine research.
And your research is really super close to my heart. I love the kind of stuff that you do because it's about reducing low value care in healthcare, really. And that's something that I think is so very, very important. But how did you get into that? How did you just decide that that's something you wanted to look at? Was there a moment?
No, I don't think it was a moment. I think it's been a process. So I first came across the Choosing Wisely campaign, maybe 8 years ago or 10 years ago, when they started bringing out the recommendations. So I was aware during my training that this was a campaign, and there was some efforts from all colleges, including the College for Emergency Medicine, to be doing stuff in the space. And it was there in the background. It never made it to the surface. I mean, during your training, you don't really have a lot of leeway. So you need to finish your training, finish your exams, and after I finished, then after I became the director of emergency medicine research, I went away to Darwin for a year. And then when I came back, I sort of knew that I would stay in Townsville for the foreseeable future, because we were in a state of flux. We moved about 4 or 5 times in 6 or 8 years, mostly for training, my training or my wife's training. And when we came back from Darwin, I was like, all right, so this is probably where I'm going to be for the next maybe at least 10 years. Who knows what's going to happen after that. And I sort of started thinking about what I wanted to do, and I sort of then I think whatever was in the background then surfaced, and I started looking at tests that the Choosing Wisely campaign had recommendations for as audits. So it all started off as an audit. So I like doing audits because it was something that I felt was a well-defined task that I could get done in 3 months, whereas a research project can go on for years. So I had done a lot of audits, and I started doing a few of these audits. And what I found in these audits was, yes, maybe anywhere between a third up to 3/4 of the tests that I looked at could be low value. So and then I sort of, and then it continued, and gradually I realized that I was more interested in it, and the PhD sort of gave me a direction, I guess, because prior to that I was okay. I'm going to do a few audits. I'm going to implement some interventions, and then I'm going to re-audit and see what happens. And then I came across all the literature, which people have painstakingly looked into the area of de-implementing low value care, and the nuances and the complexities and the challenges of de-implementation, which is sort of what the first 1.5-2 years of my PhD have actually open up my eyes. So, so yeah, I don't think there was a moment where I decided that this was
Mm,
it. It was probably bubbling along under the surface, and
mm.
as I've spent more time in practicing emergency medicine as a specialist, it has become sort of gradually more well defined and clear in my mind.
And I like the way you said that it took you a little bit of time and to have the space to think about it. So, you've referenced a couple of times it was bubbling along below the surface, but it wasn't until you had the space to potentially stop and think about it a little more that it came up. And I also really like the story about you started with audits. Audits are a great way to have a look at the landscape, what's actually happening in the space that you work that you might want to, or is it a problem? If it's not a problem, good to go. But audits are a really nice way of just understanding the landscape. So for you, it was about time to sort of sit back a second and think and remember. And also then just doing a little bit of what's out there in terms of what's my place of work looking like as an audit. How do you then navigate that tightrope? Because your job is really full on. You're doing lots of research and you're directing others in how to do it. How are you navigating that tightrope between clinical work and research so that you get that space to think?
Well, I'm lucky in the sense that we have dedicated non-clinical or clinical support time. So all emergency physicians get 25%. I get about 35%.
Mm-hmm.
So that works out to 30 hours a fortnight of paid time, where all I do is research and anything related to research, including the current interview. So I think that probably plays a huge role, because I know my peers, emergency physicians who are interested, have major difficulties, even with that 25% clinical support time. They have other portfolios. So I have, my research is my only portfolio. So I don't do anything else. I used to do audits, but I have sort of moved away from it because I simply don't have enough time to do those audits. So I think that probably is help. And I think, and I've always said that I like asking questions, and I've always had that in me, and always been this person, whether I'm not sure how it developed. So I have this questioning the status quo. Even before I was a doctor, I was always questioning people's assumptions and behaviors. So it sort of appeals to me deep down, I guess. And that probably really helps, because that a lot of the times that's what keeps me going, because I do stuff, because with the PhD and there's no dedicated time. I do use some of my clinical support time, but I don't think it's justified to use the paid time by the hospital towards my PhD entirely. So I do end up doing a significant proportion of my non-work time. I spend it on research, and I don't sort of compartmentalize it. So this is PhD, this is my hospital related work. It's all research. It's all learning, and I feel I learn every time I get involved in a research project. I learn lots about the topic itself, which I probably wouldn't have otherwise. And obviously I'm not doing everything that I want to do, but I think I've realized that you have to make choices about what you want to do as you progress in your career. So you can't do everything. So I would love to do a lot of other stuff, love to go to conferences, read lots of stuff, but there's only so much time in a day.
Yeah, that's an interesting thing to say. Like, you can't do everything. So you do what motivates you the most. And I really like that idea about curiosity. And it leads me into the next question then about that, is that you have innate curiosity. It's been there for a very long time. You're questioning, you want to know what's going on. And And you've mentioned you're doing a PhD. But do you think for those people who are watching our conversation, do you think they need to do a formal research degree in order to do research?
Not at all. I have met very experienced and expert clinician researchers who have not done a PhD. In fact, throughout my training, and I think they're my mentors. They were not my formal mentors, but I look up to them as my mentors. I've always had in different hospitals that I've worked at, one particular person was a very critical appraiser of literature, and none of them have their PhDs. They're still really good at what they do. In fact, they probably nurtured that curiosity, or my questioning attitude throughout. And one of the reasons why I sort of stuck with research, because research can be quite off-putting for a few people, with the back-end process issue, whereas the thing that drives us is the question and the answer to the question. But in getting from the question to the answer, there is a process for a reason. So which can sometimes be challenging, but I think the mentorship I had, mostly informal mentorship, and one of them is my colleague now here, and I work with him on research projects. He doesn't have a PhD, but I think he should, but he doesn't. So I don't think having a formal research degree is necessary. It helps. Just in the last year that I've been doing it, I like that. I'm realizing where the gaps in my knowledge and skills of doing research are. And one of my mentors, who again is still my colleague, and it's not here anymore, but he was my predecessor in the job. So I asked him when I took over the job, it's like any pearls of wisdom, and he said, no, just keep doing what you're doing. You do best. You learn best when you're doing stuff that you're supposed to do. So you can do a course, a research course or a master's, but you still need to be doing it. But I guess that's the beauty of a higher research degree. You are learning by doing. So I don't think it's necessary, but I think for all researchers who can afford to and who have the space and time, and that's eventually what it boils down to, having the space and time or making the time, I would strongly encourage them to consider a research degree at some point in the career. And look, it's taken me nearly 5 years as a consultant to have that ability to sit back and say, yep, I have a reasonable degree of stability in my personal life, because to start thinking about something. And luckily I had a very supportive wife who said, hey, look, you're doing all this stuff anyway, why don't you just do a PhD? So and that probably helped as well, because it's a major commitment. It's a long-term commitment, and so in answer to your question, no, I don't think it is necessary that you have a PhD, but I think it helps.
And you've spoken, it's great. There's mentorship in there. There's challenges about, research, needs to be rigorous. And you said for all the right reasons, and it's true, but it can be tedious at times. You do need to, follow that process. For the people that you work with, for the people who are less experienced in research than you, and if we're talking to a broader audience, to the people who are watching us today, you've given some great tips, but what would you say to someone who is interested in research but is a little bit scared about what that might look like? What would you say is the first step for them to take?
I guess it depends on where they are, and I think the interest is essential or necessary, but not sufficient, because I was interested when I was a registrar, but I simply didn't have the time. There was too much with balancing work and personal life and doing research on top of that, because trainees don't get any clinical support or non-clinical time. So I did try to do when I was in Bundaberg, where I met one of my mentors who had a massive influence on me, who's a researcher. I did try to do a project. It went nowhere. And I think that ability to accept, I won't call it failure, but non-starters, is important. The perseverance and persistence are important. But as a first step, and I spoke to a small group of budding researchers here at the hospital early last year or late last year, sometime, where I said, do an audit. So an audit, I see audit and research as sort of two faces of the same coin, where you audit the practice, and which then could probably lead on to questions. And in fact, my entire PhD came out of a single audit that I started. It takes time, obviously, so you need to refine that, because audit is quite contained, and you can most certainly complete it in 3 to 6 months, even with multiple competing priorities. So, and I know people say, oh, it's just an audit. It's not just an audit. There are audits that have massively changed and continuing to inform our practice, like the NAP4 audit, which came out of the UK. It was an audit. It's called an audit, but it is informing our airway practices across anesthesia, emergency medicine, and intensive care medicine to this date. And I think it's probably 2 decades old or something. So, and how you do the audit, and I've come to this conclusion that you need to do audit with the same rigor that you do research. So, in the same way, so that yes, the applicability of the findings might be limited, but it's still quite useful to know what's happening. And then once you've done that, then you know you can do it, and then maybe you do another one, and then that'll lead to questions, and then you start off. And I guess the interest and the passion are probably necessary basic characteristics of any researcher, because like you said, it can be a slow burn. It's a slog. So to transition to becoming a researcher from a clinician and remaining a clinician and being a clinician researcher, I think you do need all of those things to come together. But I would say probably start with an audit.
Brilliant. Fantastic. Thanks heaps for the chat today. That was really nice. I really liked it.
No worries at all.
We'll talk again soon.
Do.